Welcome to the MRCPology channel for a quick review, understanding, and revision of the topic. Imagine an older patient who is repeatedly falling backwards, has stiffness, speaks with a strained or slurred voice, and when you ask them to look down, their eyes do not move properly. The first thought may be Parkinson disease, but the early backward falls and vertical eye movement problem should make you think of progressive supranuclear palsy. Progressive supranuclear palsy, or PSP, is a neurodegenerative condition caused by abnormal accumulation of tau protein. More specifically, it is a 4-repeat tauopathy. This abnormal tau leads to degeneration in important areas such as the midbrain, basal ganglia, subthalamic nucleus, frontal circuits, and brainstem. So the disease affects eye movements, posture, gait, speech, swallowing, and behavior. Phrase to remember is this: early unexplained falls plus vertical supranuclear gaze palsy. That combination is very high yield for MRCP. Let us first understand the word supranuclear. The eye movement nuclei are in the brainstem. You can imagine these nuclei as the workers that physically move the eyes. Above them are higher control centers, which act like the manager. In PSP, the problem is not mainly with the eye muscles or the cranial nerve nuclei themselves. The problem is above the nuclei in the supranuclear control pathways. So the workers may still be capable, but the manager is defective. This explains a very important clinical clue. Voluntary vertical eye movements are impaired, especially looking down. But early in the disease, the vestibulo-ocular reflex may still overcome the problem. So if the patient cannot voluntarily look down, but the eyes move when you passively flex and extend the head, that supports a supranuclear problem rather than a nuclear or muscle problem. Why is downgaze so important? Downgaze is needed for reading, eating, looking at the floor, and going downstairs. If a patient cannot look down properly, they misjudge steps and obstacles. Add axial rigidity and impaired postural reflexes, and the patient starts falling early, often backwards. Now connect the pathology to the clinical picture. Tau accumulation leads to degeneration in the midbrain. Midbrain involvement affects vertical saccades, especially downgaze. Basal ganglia and subthalamic degeneration cause an akinetic rigid Parkinsonian syndrome. Frontal subcortical circuit involvement causes apathy, impulsivity, executive dysfunction, and reduced verbal fluency. Brainstem and bulbar involvement causes dysarthria, dysphagia, and aspiration risk. So PSP is not just a movement disorder. It is a disorder of eye movement control, posture, gait, speech, swallowing, and frontal behavior. The classic phenotype is PSP-Richardson syndrome. This is the one most commonly tested. The patient develops early postural instability and falls, usually within the first few years. The falls are often backwards because of axial rigidity and poor postural reflexes. The posture may be upright or extended, sometimes with retrocollis, rather than the typical flexed posture of Parkinson disease. The Parkinsonism in PSP is usually symmetrical and axial. That means the neck, trunk, and proximal body are affected more than the limbs. This is different from typical Parkinson disease, where symptoms often start asymmetrically in one limb with resting tremor, bradykinesia, and rigidity. Now let us compare PSP with Parkinson disease carefully, because this is a common exam trap. In Parkinson disease, the pathology mainly involves dopaminergic neuronal loss in the substantia nigra. Because dopamine deficiency is central, patients often respond well to levodopa, especially early on. In PSP, the pathology is more widespread and involves tau-related degeneration in multiple circuits, not just presynaptic dopamine loss. So levodopa response is poor or only modest. In Parkinson disease, falls usually occur later. Early falls should make you question the diagnosis. In PSP, falls occur early and are often unexplained or backwards. In Parkinson disease, eye movements are usually preserved until late. In PSP, vertical saccades become slow, and vertical gaze palsy develops, especially downgaze palsy. That is one of the strongest differentiating clues. In Parkinson disease, posture is classically flexed. The patient may have stooped posture, reduced arm swing, and shuffling gait. In PSP, posture may be upright, stiff, and extended, with axial rigidity and sometimes retrocollis. In Parkinson disease, tremor is common, especially in asymmetric resting tremor. In PSP, tremor is less prominent, and the dominant features are axial rigidity, falls, eye movement abnormality, dysarthria, and dysphagia. In Parkinson disease, cognition may be normal early, though cognitive impairment can occur later. In PSP, Frontal features can appear relatively early: apathy, disinhibition, perseveration, executive dysfunction, and reduced verbal fluency. So if the exam gives you symmetrical axial Parkinsonism, poor levodopa response, early backward falls, downgaze palsy, dysarthria, or dysphagia, think PSP rather than Parkinson disease. Do not confuse PSP with multiple system atrophy. Multiple system atrophy can also give poor levodopa response and early autonomic dysfunction. But in MSA, look for prominent autonomic failure, such as severe postural hypotension, urinary retention or erectile dysfunction, and cerebellar signs. Vertical supranuclear gaze palsy is not the key feature of MSA. Do not confuse PSP with corticobasal syndrome. Corticobasal syndrome is usually asymmetric and cortical. Look for alien limb phenomenon, apraxia, cortical sensory loss, and asymmetric rigidity or dystonia. PSP is more axial, symmetrical, and strongly associated with vertical gaze problems and early falls. Do not confuse PSP with normal pressure hydrocephalus. NPH gives the triad of gait disturbance, urinary incontinence, and cognitive impairment. The gait is classically magnetic, and imaging shows ventriculomegaly. PSP gives vertical gaze palsy, early backward falls, axial rigidity, and poor levodopa response. Do not confuse PSP with vascular Parkinsonism. Vascular Parkinsonism often affects the lower body more, with gait difficulty and vascular risk factors. Imaging may show small vessel disease or infarcts, but vertical supranuclear gaze palsy and the classic hummingbird sign point more towards PSP. Diagnosis is mainly clinical. The key clinical pattern is early falls, vertical ocular motor dysfunction, axial Parkinsonism, and poor response to levodopa. MRI can support the diagnosis. Midbrain atrophy may produce the classic hummingbird or penguin sign, where the atrophic midbrain resembles the head and beak of a hummingbird on sagittal imaging. The MRI is supportive, not the whole diagnosis. It also helps exclude mimics such as vascular Parkinsonism, normal pressure hydrocephalus, tumor, or other structural causes. Management is symptomatic and anticipatory because there is currently no disease-modifying treatment. A trial of levodopa may be reasonable if Parkinsonism is functionally limiting, but the response is often modest. Physiotherapy is important for gait, balance, and falls prevention. Occupational therapy helps with home safety, seating, transfers, and visual aids. Speech and language therapy is very important because dysphagia is a major problem. Swallowing assessment, diet modification, and aspiration prevention can reduce morbidity. Bulbar dysfunction is one of the most important clinical issues in PSP. Dysarthria affects communication. Dysphagia increases the risk of choking, weight loss, and aspiration pneumonia. So in real clinical practice and in the exam, do not focus only on stiffness and eye movements. Always think about swallowing safety. Other symptoms should be treated symptomatically, including sialorrhea, mood symptoms, sleep disturbance, and constipation. Advanced care netting should be introduced early because PSP is progressive, and morbidity is often driven by dysphagia, aspiration, immobility, and falls. MRCP trap. If a patient is labeled as Parkinson's disease but has early falls, poor levodopa response, and vertical gaze palsy, do not keep calling it Parkinson's disease. Think progressive supranuclear palsy. If you remember one thing, remember this. PSP is early backward falls plus downgaze palsy plus axial symmetrical Parkinsonism with poor levodopa response. Quick recall. A patient with Parkinsonism has repeated backward falls within the first year, an upright stiff posture, dysarthria, and difficulty looking down. What is the most likely diagnosis, and what eye movement finding makes it different from Parkinson's disease? The answer is progressive supranuclear palsy. The differentiating eye movement finding is vertical supranuclear gaze palsy, especially impaired downgaze or slowed vertical saccades. A patient has symmetrical axial rigidity and poor levodopa response. You are trying to distinguish PSP from Parkinson's disease. Which 3 clinical clues most strongly support PSP? The answer is early unexplained falls, vertical gaze palsy, especially downgaze palsy, and early bulbar or frontal features such as dysphagia, dysarthria, apathy, or executive dysfunction. Do subscribe to the channel for further videos.